as clinicians, we are requested to fill in what we call the D1s, or death notification, and give experience, even personal experience, when we given that for the first time as an intern, especially, and you are lost on what to do other than probably knowing that the cause of death. You write in as the patient has died of cardiopulmonary arrest, and then the rest follows. And this is not accurate, as we will also get to learn from today. Accurate information on the cause of death is very vital. And filling in that notification or the death certificate, it's not just for burial purposes or for subsequent management of estates, and many use as such. And sometimes we ask ourselves, what is the cause of death? We must move as healthcare workers, we must move above the assistant chief or the chief, who will fill in as probably they may wish, and especially also when we have not even built their capacity. So we need to fill in because we know the proper use of that information. We need to have reliable mortality statistics. And this is medical certification of cause of death is something which is rarely taught, or possibly maybe is recently being taught in the medical schools. As it were, maybe you rely on your seniors when you get to the health facility after finishing your training. And we take advantage of this, and probably one of the resolutions we need to come is how to do this in the pre-service, not to wait until internship. So today we have our great panelists. We'll start off with our own Dr. Walong, who will give us a brief overview of his experience on this within the country. We are expecting Dr. Sitenei, who is head of the directorate at the Ministry of Health, head of directorate of Policy, Informatics, and M&E. I don't know whether he has joined, Dr. Sitenei. Once he gets in, we'll be able to give him an opportunity maybe to give us also, because this lies essentially, it's the directorate that manages this aspect. But without much ado, let me welcome Dr. Edwin Walong to take us through this session, and we move on to the next one. Karibu, Daktari.
Right, Dr. Dan, thank you very much for the introduction and for organizing this. And I will just quickly move on to discussing the snippet. And of course, I do work at the University of Nairobi and Kenyatta National Hospital. We are sort of inseparable. I'm looking at it from a pathologist's perspective. And we all know certain things about death notification is that we do not know much about the mortality data for most of the world. And yet, just knowing who dies from what is the most basic health statistic. And because of that, we are unable to properly plan for healthcare. So we realize that all countries do have functional registration systems, so they must have that. All deaths must be recorded before disposition can occur. And death must be determined by a medically qualified person, and preferably the best medical opinion at that particular time. And if you look at our system, the medical practitioners, usually the most junior doctor is one who certifies most deaths, and I know clinical officers also do the same job in certain parts. And we expect that unnatural deaths will be certified usually by a pathologist and a medical legal system. I know we also do not have a properly existing or a properly organized medical legal system. So the end result is that most death certificates will have this as a cause of death. And there are definitely many reasons for this. We know that death certification is a difficult process. identifying, assigning the diagnosis. You first have to properly know the patient for you to really know what killed the patient and write that in a coherent diagnostic flow. So many people, because of lack of that information, probably fall back to this. And of course, I'll show you why this is definitely not proper. If you compare what we have in Kenya, where we write our medical certification, we have this area here at part 12, and it's different from what is internationally recognized or required because we are missing out on interval between onset and death. And identifying that interval is what we really need to do if we are to assign a proper cause of death. So the design of a death register is definitely one area that contributes to poor death certification, because in its very design, it doesn't seem to capture much, unlike this what we call a standard design by the WHO and the CDC, which captures a few more things, including pregnancy and some mention on the manner of death, which I'll talk about a bit later. So what's the consequence? Of course, anybody in Nairobi knows who Mbuvi Gideon Kioko is, and he had a cause of death as cardiopulmonary arrest in 2005, which I think he was able to challenge. So not having a good diagnosis, even to the actual individuals or the deceased, the family of the deceased and the society, you can see doesn't provide much information. Let me take you through a case. Sorry, I had to take you through that. And this is a surgical case that had also been diagnosed as cardiopulmonary arrest. And we did find, as a pathologist, I'll definitely show you some pictures that may have been distressing a bit. We did find, if we look at the neck during the autopsy, and I'll allude to the autopsy because autopsy is the gold standard for assigning cause of death, quite severe injury related to cannulation within the neck structures. As you can see, the carotid artery is here, and the cannulation has led to a compartment syndrome. And of course, she had lots of diagnoses. So how do we go about assigning this cause of death? We have to first list down all diagnoses we have made. And once we have diagnoses, then we need to state the likely interval between its onset and death. For example, we suspect this had occurred within hours, others within days, others within weeks, and others within months. And once we have this coherent flow, then we can sit together and think about it and then assign this as a cause of death. Of course, it looks easy if I present it this way. And in this specific case, because we had additional information from a clinical pathology meeting, the mortality meetings that we have, we were able to assign a final cause of death, as in this case, sinus bradycardia occurring due to the injury of the jugular vein, of course, with injury of the carotid body and associated with the central venous catheter. And here we are assigning provisional codes based on ICD-11. And then you notice that this individual had lots of other diagnoses. All these other diagnoses become contributory. So if you imagine trying to assign all these diagnoses on a current D1 form as currently developed, then you can see the challenges that most people do have. It will definitely, and then the fact that this requires the best medical opinion, then of course, again, we do see the challenges that people will have. At least we assigned this following a mortality meeting. And why should we use this approach? It's about the implementation science aspect. If you're to prevent this mortality or similar mortality, then we need to first improve emergency care on the management of these areas, and then eventually improve the other aspects that we are seeing down here. So this is my final slide. So my observations is that although we need the best medical opinion to properly assign a cause of death, we tend not to have this reflected in the final cause of death in many of our cases. We have a lot of descriptions such as cardiorespiratory arrest, which does not which shows that the best medical opinion is either not being utilized, or if it's being utilized, then it's being utilized inadequately. Okay. And then, of course, to provide a clinical, what you call quality assurance into the whole process, we need clinical autopsies performed, and these results discussed at a mortality meeting. And of course, this is also not discussed much in our series. Right, so I'm going to stop here and I'm going to hand over back to Dan. Thank you very much for this.
Yes, thank you, Edwin. Thank you, Edwin. Yeah, you're giving us a snippet of what happens. And as you say, most of the time, the health facility is the junior most, as they call it, the one to do the Tier 1 forms. And of course, it's so important that we take it seriously, especially coming to this, after this meeting, this webinar that we are having. I've seen Dr. Sitene has joined us. Can we make him a panelist so that you give him a few minutes to just give a few remarks as he gets in? Joseph Sitene. And as he comes along, colleagues, make use of the question and answer section to give, to make any remarks, especially ask your questions. You have great panelists here. And I want to acknowledge World Health Organization team once again. They have come on board to take us through this session, the medical certification cause of death. Dr. Sitene, are you able to speak?
Yes, I'm trying here
Yes.
with my technology, somehow a bit complicated to me.
Okay, all right.
Thank you for
we can hear
asking
you.
me to make a few comments. Thank you very much for the organizers and for the presentation that I just listened in through. I think one of the biggest problems that we face in Kenya is this challenge of not just collecting data, but even how to collect the data. I think the questions that have been alluded by Daktari in terms of registration for deaths in Kenya are really mammoth. And they affect all spectra because one, this data is the filling of the forms are done by clinicians, but also we have given non-clinical people the ability to do the same. So to triangulate this data is obviously going to be a major challenge for our generation and maybe generations to come until that point when we have the right skills at all levels. One of the biggest problems that we are facing right now in the ministry is to give the accurate data on not just the cause of death, but even when it occurs. And I think WHO is sponsoring a rapid mortality survey in, I think, 6 counties. Yes, that is good, but not good enough because 6 counties are very representative of Kenya. I don't think that will give us the full picture of the country. But yes, we must start somewhere. But I think this conversation that we are having, and perhaps in future, this is the direction to go so that as a nation, we start asking ourselves the hard questions and how we can be able to respond to them, bearing in mind the limitations that are existing in the country to an extent that if we are to plan for things, we are actually finding ourselves that we are collecting inadequate, maybe incomplete, inaccurate data. And sometimes we make decisions based on this type of data. So to me, this is a very exciting moment. It is my hope that some of the recommendations will be so realistic and practical in our setup that we can be able to pick up as a ministry and also as a country to be able to improve the mortality surveillance in Kenya. And because I am a little bit trying to lay my foot on this technology, I want to rest my case there and wish us very good deliberations. I'll be listening in because I'm supposed to be joining another meeting. But yes, I'll be here and I would really love to get the recommendations, particularly on how we are going to progress from where we are. Thank you, and over to you, Chairman.
Thank you, Daktari, and we really appreciate leadership of the Minister of Health, especially in this regard for their directorate. And ladies and gentlemen, I would like to introduce our speaker, who is Dr. Benson Droti. Dr. Benson Droti is a health systems expert with experience spanning many decades, over 2 decades, quite experienced in health systems strengthening across many African countries. His expertise in epidemiological modeling, monitoring and evaluation, and also establishing and maintaining civil registration and vital statistic systems, as well as introduction of the ICD-11, the National Classification of Disease, version 11, which is currently, I think, will only just be a hint today, but otherwise there'll be a special session on that. He's a graduate of Makerere University, that's in Kampala with MPCHB, and subsequently obtained MSc in International Health from the Royal Tropical Institute Free University in Netherlands. He also has a doctorate in public health from the London School of Hygiene and Tropical Medicine. So he's accompanied by a colleague also from WHO. He's also a health system expert, Dr. Hilary, who will speak to us a little later. But for now, Benson, the floor is yours.
Yeah, thank you so much, Dan, for this introduction. And I feel honored to be invited to speak to the team in Kenya. I think this is something the rest of the countries in the region can learn from. In my work as WHO staff, I've actually come to realize that Kenya tends to lead in so many things, and many countries play catch up. So I think this is a great opportunity for the team in Kenya and also for the rest of the countries to learn and see how best we can move this forward. I particularly liked the summary that Edwin had just given. It actually sent my mind back to what I did even when I was still practicing in a hospital here in Uganda. And at the time, of course, we used to be given police forms to fill. And each time we have the police form, the cause of death often was cardiorespiratory failure. And of course, when you reflect back, you realize that no one is alive if the heart stops beating. No one is alive if the brain stops working. No one is alive if the person stops breathing. So obviously that can't be the cause of death. And none of that information actually should make to the cause of death certificate. So we will be talking, we'll be introducing you to medical certification of cause of death. We don't have all the time to go into the nitty-gritties. We'll just try to bring out the key issues that we think you should know when you are doing medical certification of cause of death. So let me share my slide. Just a moment. Let me share my slide. And we are going to start with a simple let me know if you can see my slide, Dan.
Yes, you can see.
Okay,
Go ahead.
excellent. All right, so colleagues, this is where I wanted us to start. A very simple exercise. I want you to read through this scenario, think through, formulate the sequence of events that you think led to death. Exactly the point that Edwin just talked about. Think about that and write down somewhere what your underlying cause of death is, what your intermediary causes of death are, and what your immediate cause of death is. I'll give you 3 minutes to do that. And we will also have another one, 2 of them, then we'll go to the presentation. So this for me should be the starting point. So I give you 3 minutes, I'll be timing up. At the end of the 3 minutes, I will stop and I go to the next slide. Okay, please, you can start.
Benson, I think the last bullet is not visible well, but
The last bullet is not visible. So I can
it's
read.
partial. Yeah.
Okay, I don't know why. So postoperatively, she was not transfused because there was no blood in the bank. Her blood pressure dropped to 75 out of 40 millimeters of mercury and became unconscious. She passed away 10 hours after admission. Postoperatively, she was not transfused because there was no blood in the bank. Her blood pressure dropped to 75/40 millimeters of mercury, and she became unconscious. She passed away 10 hours after admission. So you should be done by the next 15 minutes. All right, so this is the first case. You can continue thinking through as we'll be going through the presentations. I'm not asking you to write the response in the chat or anywhere, just write somewhere on a piece of paper in front of you. And as we present, then you can reflect always back onto this and see whether your sequence of events that you'll have put on the medical certificate of cause of death is correct. This is not made up. This is a real case scenario of a mother that died in a hospital, in one of the Africa's hospitals. So I'm going to also share with you another screen. I also want you to do the same. So this is the second case of a 32-year-old gravid at 3/1+1 admitted with labor-like pains. She had one previous scar due to prolonged labor. So this is the case. Also do the same and see if you can formulate the sequence of events that led to her death. Starting with the immediate, then the intermediate causes and the underlying causes of death, rather the underlying cause of death. Also another 3 minutes. So you should be done in the next 30 seconds. Okay, so you can continue to think about these two cases. And as I said, these cases these are real cases. I have been participating in a number of maternal and perinatal death reviews in many hospitals across Africa. So some of these cases I've picked from what the hospitals actually shared. We also wanted, actually, if time had permitted, we had wanted also to get some cases from Kenyatta National Referral Hospital. And maybe I can put up front that I think after this presentation today, the expectation really from us as WHO is that hospitals across Kenya will actually start doing maternal, perinatal, and also other death reviews. That way, then we're going to improve delivery of services. You can see when you read through some of these cases, these two cases which I've put here, there's a lot that will make your heart skip a beat. Okay, so I'll just give a very short preamble and I'll define what the cause of death is. And then I'll talk about medical certification of cause of death, and also talk about how to complete the International Medical Certificate of Cause of Death. I know that Edwin shared a medical certificate of cause of death for Kenya. I think it has changed a bit, Edwin, I don't know. The interaction I've had with colleagues from Ministry of Health suggests that the form now is different. And then we'll talk about certification of perinatal deaths. And also I brought in the point of certification of COVID deaths. And we'll do some practical examples and then have discussions and of course discuss the next steps. I know Dr. Sitene said we should provide some practical guidance. Yes, we can do that as WHO, but I think you have the answers on the ground. You know, after this discussion, you will know exactly what needs to be done at the country level to improve the reporting of data on the deaths and causes of death. Now, when somebody died, just as Edwin actually already mentioned, of course, you have to examine the date. And in most cases, we don't have the opportunity like Edwin does to examine the date, because examining the date is part of the autopsy. In most cases, we rely on review of the clinical notes to try to formulate a sequence of events. So when you examine the date or review the clinical notes, of course, you formulate the sequence of events that led to death. And quite often, you'll be faced with a situation where you have more than one underlying cause of death. But the requirement, as we'll see later on, is that you can only write one underlying cause of death, not two, not three. There can only be one underlying cause of death. Where there are two, you have to choose one of them based on your best opinion, as Edwin rightly mentioned. So you fill those details in a medical certificate of cause of death. And at another time, we will talk about how to code, how to assign an ICD-11 code. ICD is International Classification of Disease. It is used to assign a code to any of the conditions to help to standardize our diagnosis. It's also a clinical tool as well. ICD is critically important because we doctors, we are fond of writing diagnosis, the same diagnosis in different ways. So you find within Kenya, somebody will write malaria in a different way. Somebody will say, okay, it is P. falciparum malaria, another one just says malaria, another one writes is a fever, but you need a standard that can harmonize all of this. So that's where ICD comes in. We'll talk about ICD in another, I think, webinar if the opportunity arises. And I think it is important that we do have that opportunity to talk to you about ICD-11 and other WHO family of international classifications. Now, what is a cause of death? Cause of death refers to all those diseases, morbid conditions, or injuries which either resulted in or contributed to death. And also they include circumstances surrounding them. We'll look at specific examples of this. Please note And this also repeats exactly what Edwin says. Definition of cause of death does not include symptoms. So if when you are when you're filling the medical certificate of cause of death, you see it's a symptom, don't write it there. It doesn't include signs, and it does not include modes of dying, such as cardiorespiratory arrest, respiratory failure, shock, arrhythmias, brain death, fever. These ones shouldn't make to the medical certificate of cause of death. So I hope from the first two scenarios that we have, you're able to knock off any of this on your medical certificate of cause of death. Because both mothers, I think, had a situation where they suffered shock, hypovolemic shock. I hope you didn't include that anywhere on your sequence of events. So you should be knocking that off as we'll continue. And also that also includes situations like anemia, which is actually a sign itself. And anemia, situations of those kinds, we'll look at some specific examples. You can include them, but they should never stand alone on a medical certificate of cause of death. We'll continue to talk about this. So this is what cause of death is. Diseases that start the sequence of events, all conditions, morbid conditions, injuries which resulted in or contributed to death, and also circumstances relating to them. And symptoms, signs, mode of dying should never make to the medical certificate of cause of death. Now, what is the importance of cause of death data? There are many reasons why we do medical certification of cause of death. But I want to move you away from the data issues. I want you to appreciate the value of doing medical certification of cause of death for the sole purpose of improving the quality of care for the patients that we care for. When you do maternal death reviews, maternal perinatal death reviews, it's about, okay, how best could we, what else could we have done to save the mother's life, to save the baby's life? That is the conversation really for me as a doctor I'm interested in. Not about the data is important, it comes secondary. But the primary reason why we're doing medical certification of cause of death, doing these reviews, is to try to see what else could we have done differently to improve the care of the patient that has just died. But cause of death information is important for social purposes. It's a legal document in many countries for burial. It is important for processing insurance. It is important for processing inheritance and settlements. It is important for statistical purposes, used to assess the general health status of the population, examine the levels and the trends and also differentiations in mortality, identifying emerging diseases and their impact, and monitoring public health programs. They also guide the resource allocation and are used to prioritize interventions. Generally, they are important for epidemiological surveillance, including social, medical, and biomedical research priorities. And also, of course, as we see in many countries, they are very important. If we had fully functional civil registration and vital statistics systems, we will be having our national databases updated regularly using the cause of death information. But of course, in many countries, we still see dead people voting, and therefore you find people who are dead are still in the database, and they are still voting. So that is a situation that we are faced with in many African countries. But with the time, I think when we have a fully functional CRVS, even this population census that we are doing, which are costing a lot of money, will not be necessary anymore. All that we need to know is how many people have been born, how many have died. You factor in migration in and out of the country. You should basically be having your country level population data for you to use. Now, just a moment. So what is a medical certification of cause of death? So the medical certification of cause of death is the assignment of a cause of death by an authorized and a medically trained clinician who fully understands the clinical sequel of disease or injury that led to death. In one of the slides, we'll be talking about who should do medical certification of cause of death. the discussion, or maybe I should preempt that. As WHO, our recommendation to countries, medical certification of cause of death should only be done by medical doctors, not a clinical officer, not a nurse, because understanding the clinical sequel of disease requires adequate medical knowledge. I think Edwin also mentioned this when he shared his brief summary, which was really intense. It requires that level of understanding. It's not anybody's business. It should be the role of medical doctors. MCCOD, medical certification of cause of death, provides a cause of death statement. By cause of death statement, we mean that it is that written information in a format used on death certificate. And the cause of death statement is provided on a medical certificate of cause of death. And I want to make a distinction here between a medical certificate of cause of death and a death certificate, and perhaps also a death notification form. A medical certificate of cause of death is the form where you fill in the cause of death information. We'll look at the form later on. A death certificate is issued by civil registry, which in Kenya, I think is in the Ministry of Home Affairs. Civil registry issues a death certificate. They don't issue a medical certificate of cause of death, but they use information on a medical certificate of cause of death to issue a death certificate. Then there is also what we call the death notification form. In countries where medical certification of cause of death is not readily done, doctors fill a very short form, what we call the death notification form. The amount of information on a death notification form is very small. It just contains basic information on who has died, okay, or somebody has died. And normally it is to notify somebody has died, and then somebody goes to do medical certification of cause of death. If it is in the community, that's verbal autopsy. If it is in a hospital setting, that's medical certification of cause of death. So these three forms, I need you to be clear about them. The medical certificate of cause of death, the death certificate, and the death notification form. They are not entirely the same forms. So how is medical certification of cause of death done? The certifier provides a clear sequence of events leading to death, progressing in ascending order from underlying cause of death, leading to antecedent or intermediate causes of death, and which eventually lead to the immediate cause of death. I hope you are reflecting on the first two scenarios, what your underlying cause of death was, what your intermediate causes of death were, and what your immediate cause of death was. The underlying cause of death is the disease or injury that initiated the chain of events that led directly and inevitably to death. So it is the starting point. What started the chain of events? It's not somewhere in the middle. This situation really started because of this condition in this patient. The antecedent or intermediate causes of death, these are conditions that led to or precipitated the immediate cause of death, but they lie between the underlying cause of death and the immediate cause of death. And the immediate cause of death is defined as the final disease, injury, or complication, which resulted from the underlying cause of death and then directly caused the death. We'll look at specific examples of this. And I hope also from the two scenarios, you were able to identify what the immediate cause of death was, what the intermediate causes of death were, and what the underlying cause of death was. So how do we select the underlying cause of death? The cause of death statement, I think Edwin mentioned this as well, is the best opinion of the certifying doctor, but also, of course, it follows certain principles. I want to repeat that. The cause of death statement that is put on a medical certificate of cause of death is the best opinion of the certifying doctor. It may not be the best opinion. I mean, it may not be the correct opinion, but it is the best opinion. Whatever you put there is your best opinion. It may change. It may change, but it is what you at the time feel is the sequence of events that led to death, that makes the medical certificate of cause of death. Of course, the certain principles. One is what I mentioned earlier already. The underlying cause of death should be able to trigger the chain of events that led to death. Two, selection of the underlying cause of death is based on one key principle, that there is a public health intervention to prevent the underlying cause of death. And Edwin also actually explained this as well. Okay. For example, if a blind man is knocked dead by a speeding vehicle, okay, a blind man is knocked dead by a speeding vehicle, the road traffic accident is the underlying cause of death, even though being blind actually made this guy vulnerable to the accident. When we talk to many countries and give them such a scenario, they say, yeah, this guy was knocked. What kick-started the event was the blindness. No, it is not. It is because the road network doesn't care enough for people who are blind. So the public health intervention there will be, can we make our roads safe for people with disabilities to use? As I mentioned earlier, several underlying causes can be attributed to death, but only one. Please, I repeat that only one underlying cause of death should be identified and written on the death certificate. In the case of death due to injury or poisoning, the external cause of the injury should be reported as the underlying cause of death. In the case of fetal death, it is often the maternal condition that has actually caused the death, is the underlying cause. So for fetal death, the underlying cause of death is always in the mother. The immediate cause of death will be in the fetus. I mean, in the fetus, or in case of neonatal death, it will be either in the neonate or in the fetus, but the underlying cause of death will always be in the mother. If the cause of death is unknown, even after you have done thorough investigation, you are better off saying you don't know the underlying cause of death. It's so correct to say the underlying cause of death is unknown. Of course, in most cases, if you interacted with the patient before he or she died, you will normally know what really is the sequence of events that led to death. So let us look at this example together. And I also need you to formulate a reasonable cause of death statement. So this one we're going to discuss straight away. So you formulate a reasonable cause of death statement for a chronic alcoholic man who died after developing liver cirrhosis, portal hypertension, asterixis, hyperammonemia, and hepatic encephalopathy, which resulted in respiratory arrest and asystole. So I've put a note here that cause of death statement should not include signs, symptoms, or mode of dying. So I give you just 1 minute to try to think through what the sequence or what the reasonable cause of death statement for this patient will be. 1 minute, please. Think through. So as I mentioned, what we're going to do here, we're just teaching the basic principles. We'll not be able to explore all the potential scenarios that you'll be faced with in the field. But what is important is, as we'll talk about later on, is that it is actually important to be discussing some of these cause of death statements with colleagues. If you are stuck, bring on board your colleagues, discuss, agree. And then before you fill the death certificate, as Edwin said, you can first write down somewhere, and then you transfer the information onto the death certificate, cause of death certificate. All right, so you should be finishing in the next 5 seconds. All right, so when formulating the cause of death statement for this kind of scenario, some of the conditions should, of course, be excluded. So here I've tried to strike through some of them. Chronic alcoholism, I've left it. Liver cirrhosis, I've left it. Portal hypertension is a sign, I've deleted it. Asterixis is a sign, I've deleted. Hyperammonemia is a sign, I've deleted it. Hepatic encephalopathy, I've left it. Respiratory arrest, the terminal O is a mode of dying, I've deleted it. Asystole, or anything related to bradycardia and so on, these are terminal events or modes of dying that shouldn't make onto medical certificate of cause of death. I've also deleted that. So if you formulated the cause of death statement correctly, it should look like this. The immediate cause of death will be hepatic encephalopathy. your antecedent cause of death will be liver cirrhosis, and your underlying cause of death, that is the condition that started the whole process, is your chronic alcoholism. So this is what should be on your cause of death certificate. I hope many of you got this correctly. And it is, of course, practice that will make it perfect. So if you continue to practice, you continue to fill this cause of death certificates, you'll be an expert on that. The second scenario is also here, is of a 40-year-old female who was admitted in a coma in the emergency department. She was 80 months pregnant and had only one antenatal visit at 32 weeks of pregnancy. This was her first recorded pregnancy. Her blood pressure was unrecordable, and she had a very thin pulse. She had severe pallor of the mucous membranes. According to information provided by her husband, she had had genital bleeding for more than 1 week, which at the beginning was of little intensity, but progressively became severe. A diagnosis of severe acute anemia from hemorrhage due to abruptoplasty was made. She was transfused with blood, and emergency cesarean section was performed, and the dead fetus was delivered. The mother also died hours after cesarean section. So I also want you to think through for 1 minute on what your cause of death statement will look like. What will be your immediate cause of death? What will be your antecedent causes of death? And what will be underlying cause of death? 1 minute, please. You should be done in the next 10 seconds. All right, so you can write that, you can write your sequence of events somewhere, and let us continue. So the reasonable cause of death statement for the mother. So maybe just before, when you have a dead mother and also a dead baby, you are going to complete 2 medical certificates of cause of death. The civil registry that issues death certificate will only issue death certificate for the mother. I think that's the case for Kenya as well. In many countries, death certificates are not issued for stillbirths or dead fetus. But the mother will receive a death certificate from the civil registry, but not for the baby. But from the health facility, both the mother and the baby will have a medical certificate of cause of death given to the relatives. That's very important for you to know. Now, the reasonable cause of death statement for the mother, immediate cause of death will be severe hemorrhage. I've put it here and I've put in a bracket. Note, this is a non-specific process that should never stand alone on cause of death certificate. The underlying cause of death is abruptoplasty. When you become an expert in cause of death certification, actually you will automatically eliminate severe hemorrhage. But I want to mention something here. There are certain conditions that are non-specific, like severe hemorrhage, that are nationally important, that the governments are reporting on, that when you go to statistics, you'll find information on them. You want to know how many mothers are dying of severe hemorrhage, how many children are dying of birth asphyxia. Much as we say on the cause of death certificate, those informations are trivial, there's something to make there. As a country, you can decide to say, I want that information. I want information on severe hemorrhage among the mothers. I want to have statistics on it. It will be done. So yes, it is non-specific, but there's a lot of literature on hemorrhage among mothers. Of course, the underlying cause of death here is abruptoplascentia. This is what kickstarted the whole event. Now, the second is for the baby. The immediate cause of death will be intrauterine hypoxia. Again, this is a non-specific process that should not stand alone on a cause of death certificate. Always, what has caused a hemorrhage, what has caused a hypoxia should be mentioned. Don't write severe hemorrhage and stop there. No, we need to know what is the cause of the hemorrhage. There is intrauterine hypoxia, yes, but what caused it? So don't have a death certificate where you just have intrauterine hypoxia. Experts will only write for the baby and the mother, cause of death is abruptoplascentia, both as immediate and underlying cause of death. We will see examples where when you have only one line filled, it is both the immediate cause of death and also it's also the underlying cause of death. I hope this one is clear. Now, let's look at the International Medical Certificate of Cause of Death. You may not be able to see all the information here clearly, but I'm going to split it up a bit so that you can see the details of this form, what is really there. All countries in the African region and all the member states of the United Nations are now moving to implement this medical certificate of cause of death. It helps to standardize information across countries and also within the country as well. In a number of countries, actually, there are different medical certificates of causes of death. One country can have 3 or 4. We know these examples in Africa, there are many. But having one standardized form ensures comparability and the standardization of reporting of information on the death and the causes of death. So I know that Kenya has moved to this international, at least have aligned their form to the International Medical Certificate of Cause of Death. And Kenya has also gone ahead to develop an electronic tool, an online electronic tool for medical certification of cause of death. If you had time, we had actually wanted Minister of Health in Kenya to come and talk about that tool. It's very, very important. Now, we have the administrative part and the demographic section of the form. This part of the form is what the country can play with based on the level of data disaggregation that the country requires. So it is, you can provide as much information as you want as a country. This can include information on the residents, on your national identification number, the age of the disease, the occupational education level, and so on. This is entirely up to the country to change. But the rest of the section of this international form shouldn't be changed. It remains standard because it is to help standardize reporting. If you can add more information, but you don't remove any information which is there. So there's frame A, part 1 and 2. This is where you provide the cause of death statement, actually the sequence of events. So you can see 1, it says report disease or condition directly leading to death on line A. That will be the immediate cause of death. Report the chain of events in their order and then show the underlying cause of death. So we have provided only 4 lines. You might find a situation where there are so many events that are in between the underlying cause of death and the immediate cause of death. There are many of them. You don't need to report all of them. You can pick the key ones. Once you have the underlying cause of death, you have the immediate cause of death, whatever is in the middle, you can pick the critical ones that you feel should be there. You can knock some of them off. So this part, 4 lines are provided for recording the sequence of events that led to death. The immediate cause of death always goes on the first line. And there are situations where this may be the only condition recorded if there's no other conditions in the sequence. For instance, somebody is shot with a gun and died instantly. The cause of death is gunshot wound, which is both the immediate cause and also the underlying cause. You may just feel one line, gunshot wound. Somebody shot on the head, dies instantly, nothing more, that's it. So only one line is filled. That one line you fill becomes both the immediate cause of death and also it is also the underlying cause of death. Then the other conditions leading to death are entered in a sequence on lines B, C, and D, with the underlying cause of death on the lowest line. So if you fill one line, as I've just explained, say you fill only line A, your line A will be both the immediate cause of death and the underlying cause of death. If you fill line A and line B, your line A is the immediate cause of death, your underlying cause of death becomes in line B. So the lowest line, the lowest filled line always becomes your underlying cause of death. We have been to countries where we do this training, give them assignments, okay, fill this form. You find they fill line A, they skip B, they skip C, and then they fill underlying cause of death in line D. The assumption should not be that underlying cause of death is always on line D. No, it is the lowest filled line. Edwin talked about this. The interval between onset of the condition and the time must be filled. Those scenarios I gave, I thought I just didn't want to include anything on time because it takes a bit of time for people to compute and so on. But time interval must be filled. Interval may be instant, it may be in minutes, hours, days, months, years. Edwin mentioned this already. There are situations where you don't know the interval. It is absolutely correct to say, I don't know. So the interval is not known. You can feel unknown for the time interval. And then the second part, number 2 of frame A, is used to record other conditions that are not in part 1, but were present at the time of death and may have contributed to death. If we go back to Edwin's example, he recorded other examples. These persons had HIV and other conditions. So these conditions that were present in this patient, but are not part of the sequence of events in lines in part 1 are recorded under this section. Now the frame B of the international classification, I mean in the international form, actually is the part where you can provide more detail. And the details are often relevant to report, to do coding and also do epidemiological analysis of data for deaths due to external causes, maternal deaths, perinatal deaths, and deaths due to post-procedural conditions. So we will share these slides with you. Please try to familiarize yourself with information on this cause of death certificate. But here we have information on whether surgery was performed for this patient in the last 4 weeks. You need to provide that information. For every condition, whether it is malaria, you must fill this part B. If it is not, you say no. If it was a yes, you say yes. Then manner of death. We'll talk about the manner of death. And Edward mentioned this as well. If you recall, he said for any death due to external causes, where the manner of death is unnatural, where somebody is suspected to have been killed or has been knocked by a car and so on, the manner of death in that case is considered unnatural. When somebody dies of a disease or of age-related conditions, that is called natural death. So you need to report the manner of death in this part. And then sometimes if somebody is hanged, is sentenced to death by the court, and then is sentenced to death, and then either is electrocuted or hanged, that manner of death is still unnatural, but it is a legal intervention. Where you don't know, or if it is still pending investigation, you feel the manner of death is still pending investigation. This is where, especially for unnatural cases, this is where autopsy becomes critically important. Then you have place of occurrence of the external event. If it was a gunshot or somebody was involved in an accident, you need to state the place where this event really happened. And then for perinatal deaths, I think there's a lot of information on this. So whether this was stillborn, was the multiple pregnancy, you provide all that information in there. Previously, there was a separate medical certificate of cause of death for maternal and perinatal deaths. With this form, actually that becomes obsolete. You don't need any extra form apart from this. If you need additional information as a country, you can add it, but you can use this form only. Then you have the section for maternal deaths. So if somebody who died was a woman pregnant, you have to fill this part. Whether the woman was an 80-year-old, you still have to fill this part. You say, no, the woman was not pregnant. Even the woman was 100 years and there's no possibility that she'll ever get pregnant. Okay, so I've already explained the manner of death. As I said, it's a classification of death based on the type of conditions that cause the death and circumstances under which they occurred. So it can either be natural or unnatural. Deaths that are solely due to disease or aging process are regarded as being natural in manner. Deaths resulting from injury or poisoning or external causes are unnatural. Deaths in which the manner cannot be determined are usually described as indeterminate in manner. So you just say that. Now, the do's and don'ts. All entries on the medical certificate of cause of death should be written clearly and preferably in black ink. We don't recommend you using abbreviations. You don't alter anything and you don't delete anything. If you make a mistake, sometimes it's better you pick another form and fill. And be as specific as possible in reporting your cause of death. Provide a very clear sequence of events leading to death. Ensure that the recorded conditions are part of the disease sequel. At this point, is very important. The disease sequel, A should be able to contribute or lead to B, and B should be able to lead to or contribute to C. Okay, let me do it the other way. D should be able to lead to or contribute to C. C should be able to lead to or contribute to B, and B should be able to lead or contribute to A. The disease sequel is very important. I'm talking to medical doctors here, and you know what I mean by disease sequel. I'll repeat this point. Symptoms, signs, mode of dying should not be recorded on the form. And very important, I know many of you are very senior medical doctors, and many times, like if you work in a teaching hospital, you have senior housing officers who are doing a lot of the work, and all that you do is to sign. Do not sign a form that somebody has filled if you haven't reviewed the case. Don't sign, because a medical certificate of cause of death anytime can turn into a legal document. You don't want to go and appear before a judge and failing to defend information that has been filled there just because you appended your signature. It's an individual decision to fill, and when you fill it, sign it. So whoever fills it, signs it. Don't sign because Benson has filled the rest of the details, you trust Benson, and they're going to sign it. No, that shouldn't happen. And do not forge a diagnosis of cause of death. If you're not sure, you are better off saying you don't know. Don't forge. I've been to countries where we're having this session, they say, but I think that death, we can write this. No, don't forge. If you're not sure, just say, I don't know the cause of death, full stop. Time interval, we have talked about it, it should be filled. And if both mother and baby die at birth, again, I've mentioned this, both two separate medical certificates of cause of death should be completed, one for mother and the other one for the baby. Sorry for the repeat of information, but it's also important for sake of emphasis. Now, who should do the medical certification of cause of death? I mentioned this. Regardless of whether the law requires it or not, it's the professional responsibility of the attending doctor to do medical certification of cause of death. As doctors, for us, completing a medical cause of death certificate should be part of our patient's end-of-life care. It is our responsibility. Let us not look at it as somebody else's responsibility. It is a part of the end-of-life care. When you discharge a patient, you always write a discharge form. When you're discharging a patient who has died, it's our responsibility to complete this medical certificate of cause of death. For every patient that has died under our care, we should be able to fill this medical certificate of cause of death form. Within each facility, actually, we recommend that a medical team can be put together to do medical certification of cause of death, just to help with the discussions, to understand the issues around the disease, because as I mentioned earlier, the primary reason for doing this certification shouldn't be about reporting, should be about how do we do better with the next patient? How do we improve the quality of care for the next patient? So bringing everybody around to discuss what could have gone wrong, what we could have done better helps to improve the care for the patient in general. In facilities where there is no medical doctor, we are recommending that you use what we call the verbal autopsy tool. We haven't put any slides on verbal autopsy tool. Verbal autopsy tool is a tool for certifying a cause of death that occurs in communities where there's no doctor. So we are also saying, okay, if a death occurs in a primary healthcare facility where there's no doctor, actually the VA tool can be used to certify the cause of death. The psychometric properties of VA tool is similar to MCCOD form filled by a medical doctor. So we are still getting very good information. So, as I said, it is important for the team to discuss and agree on the sequence of events that led to death before filling the medical cause of death certificate. Edwin also made this point. First, write them somewhere. Agree on the sequence of events. So, okay, I think this is the immediate cause, this is the intermediate, this underline, then okay, let's pick a medical certificate cause of death form, then you fill it. Okay. There are situations where this is a question that comes all the time when we interact with the countries. What do we do when somebody is brought in dead? And that's a very common situation that we face. So when somebody arrives dead, sometimes the cause of death is obvious. You may see a bullet wound on the head, for instance, or injuries from a road traffic accident. That's obvious. But where the cause of death is not obvious, then the point that Edwin made, in autopsy is the first recommended step to ascertain the cause of death. I mean, if it was possible, every death should have had a proper autopsy, proper postmortem done for every death. But we don't have that luxury. We don't have enough pathologists in Africa, and I believe in Kenya as well. So there are not enough pathologists to be doing postmortem for every death. But autopsy is recommended for a dead on arrival case. Somebody's arrived dead, please think about autopsy. Don't go and start guessing the cause of death if it is not obvious. If you can't do postmortem, just record the cause of death as unknown. Now, let's briefly talk about certification of perinatal deaths. And I will ask you to look up the definition of what a fetal, I'm sure you know this already, you are very senior in this area, fetal death, perinatal death, stillbirth, live birth, and also the WHO definition of what a maternal death is. I'm not going to talk about that, but I'm just going to go straight away on how we can certify that. So the immediate and distant cause of fetal or neonatal death are usually in the fetus. I mentioned this already. The underlying condition is often in the mother, is the maternal disease or condition that affected the fetus or the neonate. This may include diseases or conditions of the mother, pregnancy, labor and delivery, placenta, and cord, which may have had some adverse effects on the fetus. Other circumstances which may have had a bearing on the dead fetus, and of course also on the mother as well, can also be put as underlying cause of death. And this include unattended delivery, adverse reaction to a drug, or home or roadside delivery, or trauma. Again, be specific. Do not use terms such as asphyxia and prematurity unless it is the only known condition. If no major disease or abnormality can be found, just state you didn't find any abnormality. Some examples of perinatal conditions that may be certified are the rhesus hemolytic disease, pneumonia, intracranial hemorrhage, respiratory distress syndrome, meningocele, intrauterine hypoxia, and so on. But intrauterine hypoxia only if there was if there was clear evidence of this, either clinically or for example, fetal distress, or at autopsy, you find widespread petechial hemorrhages in the fetus or in the neonate. So maternal conditions that can actually cause fetal death, there are several. I'm sure you know many of them. These include diabetes mellitus, cardiac disease, renal disease, and so on. I'm not to go through all of this. I'm sure you know most of them. Now, certification of COVID deaths. I think I need to take a few minutes to talk about certification of COVID death because we also do have mothers that die when they have COVID. So, definition of COVID death by WHO is that it is a death resulting from a clinically compatible illness in a probable or confirmed COVID-19 case, unless there is a clear alternative cause of death that cannot be related to COVID-19, for instance, trauma. And for you to say it is a COVID death, if somebody had a COVID there should be no period of complete recovery from COVID-19 between illness and death. Then that qualifies to be a COVID death. There are also definitions that we use for surveillance. We have the suspected case. I'm not going to go through that. You can review this on your own. We also have the probable case, and we also have the confirmed COVID case. Now, there are clinical aspects. So the certification of COVID death combines both the surveillance classification and also the clinical aspects of it. We will see specific examples of this. So fever and respiratory symptoms, these are cough, shortness of breath, sputum, acute or severe fatigue, myalgia, and anorexia. These are common symptoms in COVID patients. I'm sure you have many that you can add onto the list. Then you have also symptoms that you can see on radiology or CT scan, multiple small patches, shadows, interstitial changes, obvious extrapulmonary bands, and so on. These you can find on CT scan and other imaging services that you have in the country, MRI scan and so on. Now, how do we record COVID-19 death on a medical certificate of cause of death? The principle is the same. That's what I've been talking about. The same principle applies. So COVID-19 should be recorded on the medical certificate of cause of death for all dissidents where the disease caused or is assumed to have caused or contributed to death. The certifying physician is the best placed to assess the circumstances of death. I will repeat this. A medical certificate of cause of death is the best opinion of the doctor. This is, if there's nothing you're taking home with, just know this. It's your best opinion. So the terminology, the official terminology of COVID-19 should be used for all certification of this cause of death. Specification of the causal sequence leading to death in part 1 of the certificate is important, and this is the same sequence of events that we should be talking about. In the cases when COVID causes pneumonia and fatal respiratory distress, both pneumonia and respiratory distress should be included along with COVID-19 in part 1. Certifiers should include as much detail as possible based on their knowledge of the case, as from medical records or about laboratory testing. This last bullet point is important, particularly where somebody else is going to be picking the clinical notes and doing the coding or doing the certification. So, but where we're moving, we want doctors to do both medical certification of cause of death and also assign the ICD code. And my hope is that Kenya is where we're going to start this with. Now, the comorbidities, we know that COVID, the severity of COVID is associated with existing comorbidities. So there's evidence that many people with existing chronic conditions tend to have severe form and also tend to die. So that information should actually be captured as well. Now let's look at an example here. So this is one example of a COVID death. This was a confirmed COVID case. So this person had acute respiratory distress syndrome. This is different from respiratory failure. I need to let you know this. Acute respiratory distress syndrome is different from respiratory failure. So that was due to pneumonia, and then that was due to COVID. So the manner of death is disease. This is clear, a sequence of events here. So the underlying cause of death is COVID-19 test positive, because we are combining the surveillance, the case definition with the underlying cause of. There will be a situation where you said it's COVID-19, but a probable case. There will be a situation where it is COVID-19, but suspected case. We have examples of that as well. So this is another one, acute respiratory distress syndrome, pneumonia, and suspected case. This is suspected COVID-19. The first one I put was confirmed case, because there was a laboratory diagnosis of COVID. The suspected case is based on the clinical definition, rather on the case definition. So you can have suspected COVID-19 case. Then we have another one here of a pregnant mother that died of COVID, suffered acute respiratory distress syndrome, had pneumonia, and COVID-19 complicated by pregnancy. You can see these combinations. And the days and so on, we have put them there. And second last is somebody who was knocked, okay? Somebody who was knocked, he has COVID, he suffered multiple injuries. The cause of death, immediate cause of death is multiple injury. The underlying cause of death is the motor vehicle accident. Much as he had COVID, it wasn't a COVID death. He died with the COVID. He didn't die of COVID. So COVID is put in the other significant conditions that contributed to death. So where there is a COVID, you still report, even if the person was asymptomatic. We want to get that information. These are some of the rules that we put in place. Even if the person was asymptomatic, was healthy and everything, had multiple injuries, motor vehicle accident, but COVID should be recorded still in part 2 of frame A. So in this case, it is not a COVID death. And also another person died of myocardial infarction, and he happened to have had COVID. And I said, if you just fill one line is both the immediate and underlying cause of death. And this person again is not a COVID death, much as he had a COVID. So what are the follow-up actions? The first thing we want to suggest is that we need this training to be cascaded to all hospitals. I know we have so many doctors that have joined, but within the hospitals, then you should try to also have this training and make maternal and perinatal death reviews in the hospitals as a routine part of our work. Not just maternal and perinatal deaths, but also any death that you feel could have been avoided should actually make it routinely. I mean, we should routinely review them. That really will help us improve the care of the patients. But a lot of the recommendations are at strategic level. We do have a whole write-up around this. We can share with Dr. Setene later on. But there should be a policy framework for medical certification of cause of death. In many countries, as doctors, we still feel certification of cause of death is not our responsibility. So at a strategic level, then we need at least some kind of policy framework that supports or that compels medical doctors to take lead, to take charge of certification of cause of death. Medical certification of cause of death will be done in all hospitals, and verbal autopsy in communities and primary care facilities, or where there is no medical doctor. We don't have situations in many African countries where we have a hospital without a doctor. So where there's no doctor, we are recommending verbal autopsy. Where there's a doctor, we're recommending that train the doctor to do medical certification of cause of death. Maternal and perinatal death surveillance, this is the go-to place in many countries now through sentinel sites. Sitine mentioned that WHO is supporting Kenya to do mortality surveillance in 6 sites. Of course, when we do have an approach to compute the sample size, the number of clusters for doing this surveillance for mortality, and quite often it tends to be very expensive for countries. So we are recommending to countries where you plan to do mortality surveillance, you can start small, even if you start with 1 site, then increase to 2 to 3 and so on, until you achieve the sample size that is able to provide representative data. But the bottom line is that at the statistical level, we're not at the moment looking at the exact numbers of deaths or causes of death. We are looking at the pattern. Is the sample size that we are using, or the sites that we're doing surveillance for, are they able to give us a direction, a policy direction, a strategic direction? Are we able to know the pattern of diseases, what is killing people, and so on? That's what we are focusing on currently. But of course, with time, we really want to count absolutely how many have died and how many have been born in the country. But currently, the focus, since that's not possible, let us look at what is feasible, what can we do? Are we able to arrive at the disease pattern, the pattern of mortality in the country? So that's really what the focus will be, even for Kenya as well. Then one important thing is, I'm happy I'm talking to you who are from teaching hospitals as well. You can actually introduce a module in your teaching hospital on medical certification of cause of death. So that when doctors are qualifying, they come out with that knowledge, including ICD 11 that we'll talk about sometime later. They should come out with that knowledge. We don't have to start now struggling to teach people how to do medical certification of cause of death when actually they can already be taught in the medical schools. Then electronic tools for medical certification of cause of death that I talked about, Kenya has already developed that. Another opportunity, it really will be helpful for the ministry to do the demo for this team to see how you can use the electronic tool to do medical certification and coding of cause of death. Kenya has it. It is very beautiful. It is working very well. We know that there's a lot of fragmentation of information on births, deaths, and causes of death, which unfortunately are partner driven. And even within the countries, for instance, in Kenya, you have the Ministry of Health, then you have the civil registry, and all these are not harmonized enough. I know Kenya now is moving in the direction of harmonizing this. They are currently working together to come up with a common approach between the civil registry and the Ministry of Health. So that really is helping. So fragmentation should be eliminated. We need to have a common platform. We don't need to have 2 reporting forms in a hospital for civil registry and then for Ministry of Health, and also maybe a 3rd one for partners. We don't need that. All a country needs is one system of reporting information on births and the deaths and the causes of death. And this system should define the data needs of everybody. Whoever needs information should be able to go to a common pool, either DHIS2, another similar system, to collect the information that they need. Then importantly, capacity for analysis and use of data on a death is very important. We often say where data are used, the quality will improve, the availability will improve. Where data are not used, no one cares. Overall, improving information on the death and the cause of death cannot happen in silos. It has to be within the national framework of the National Health Information System. So as I said, a lot of this information is actually written up somewhere. We can share that with Dr. Stene and his team and have further engagements on this. So I think I will stop here, and I don't know whether there's a possibility to get some questions from participants and so on. Otherwise, thank you so much, Dan, and I hand over to you.
Wow. Thank you so much, Benson. It has been great listening to you, and thank you. There are many questions, some of the comments, wonderful presentation, and much appreciated from colleagues who have joined in. Just to note, I think we had in the presence of Chief Government Pathologist, Dr. Johansen, has joined us in. I think we have a few questions here. I think in the interest of time, I think we'll go through them, and I'll request Hilary also to help me here. But first of all is this question from Daniel. And Daniel says, any efforts by anyone to change the DA1s? I think you have mentioned that this is the D1s, not DA1s. DA1s, that's the dot for the death notification. It is true that it's an impediment to the proper certification. I don't know how long, do you have any comment on this, whether this has changed? Even the postmortem form is not friendly. Dr. Walong?
Maybe also, Dan, maybe
Yes.
also if Dr. Setene or colleagues from the ministry can comment on the revision of the tools.
Of the D1s, yes, okay. I don't know whether he said he was joining us. Dr. Setene? Maybe Walong can, unless someone else wants to.
Of course, yeah, I highlighted that as a challenge because I know most institutions are still using the forms that have been defined by our Registration of Births and Deaths Act, and in the police form, the postmortem form, by the Criminal Procedure Code, 2 laws that right now are in need of review. Good thing is that Dr. Johansen Odor is here, and I hope he will make a comment on them, but definitely we are part of the team that are trying to push for a review of these 2 documents and 2 pieces of legislation as well. Thank you.
Okay, thank you. I think this Stanley must be speaking about the electronic. Does the death certification has a backup system? I don't know, should have been CTMA or because Or Hilary, do you have any comment on this? If you're
So I think of course, I think what Edwin showed, the D1 form, I think it's in triplicate, as it were. I was aware of the initiatives that were there between the Ministry of Health together with the Civil Registration Department in terms of modernizing or adopting the MCCOD, the International Certificate of Medical Certificate of Cause of Death. And I think Benson has alluded to this. The discussions, of course, around once you start using electronic systems, there has to be provision in terms of making sure that your electronic system can be able to preserve those particular records, and the kind of data flow. And I guess the ministry and the civil registry team would have to iron out in terms of the data flow, how the data flows from the Ministry of Health all through to the civil registration department as well. But yes, I think there are, at least within the paper-based systems, there are provisions for backup on this. But I think the most important part is if the quality of what is in the paper-based systems is not good, then certainly it will still remain a challenge. Over to you, Dan.
Thank you. Thank you. Benson, also let me acknowledge the presence of Dr. Koskei from the University of Nairobi and Kihara. And those are also great teachers. And I think when you talk about MPDSR at Kenyatta National Hospital, they are model and they run that very well. I think they'll get a time to speak about it when we come to one of the questions here. Benson, is the root cause analysis done to come up with the preventive measures? I think is.
Yeah.
You do root cause analysis?
Yes, thank you. Yeah, yes, absolutely. And I lead WHO's work in the African region on health information system. Anything that's data is what I'm interested in. But whenever I talk about medical certification of cause of death, I want to remove data and health information out of the picture. The point on the root cause analysis to find a preventive measure is the appropriate one. Let us do this for the sole purpose. The primary purpose of doing this would be to improve the care of the patients. Data collection will be done, yes, but the primary reason why we want to find what went wrong, what could we have done better. These reviews are critically important and should become a routine part of our work. Over.
Is it right to indicate TB and HIV/AIDS as a cause of death? Tuberculosis?
Yes, absolutely. HIV and TB is an opportunistic infection. So HIV is in the sequel of disease. So TB, any other opportunistic infection associated with HIV is in the same, can be put on the same frame, part one of frame A. With HIV, always the underlying cause of death leading to TB or leading to pneumocystis carinii, pneumonia, anything. That's perfectly fine, yes.
Wouldn't the injury caused by road traffic accident be the immediate cause of death? Assuming it's a road traffic accident, head injury, would that be the immediate cause of death?
Yes, that's correct. So you can have your underlying cause of death will be the road traffic accident. Your immediate cause of death is the injury. So any injury, be it multiple injury or whatever, is the immediate cause due to a road traffic accident. So the underlying cause of death is the road traffic accident.
I think this one you already talked about. Are there situations where you don't have a sequence of events, you only have the immediate cause of death as, is it in order to put only that diagnosis?
Yes.
I think you said that,
so,
yeah.
Yeah, I did mention that. So there are situations where you only have one diagnosis. You only fill one line A. So that when you fill only one line A, it is both the immediate cause of death and also your underlying cause of death. I gave a specific example of this, a gunshot wound, and also the last one I think was something related to myocardial infarction. So you can have that. Okay,
one of the participants is asking, Felix is asking whether these slides which you said you will share, would you allow them to use them in any other fora? Maybe like you talk about cascading the training.
Absolutely. This slide is there for us to use.
Okay, thank you. Now, one of this reminds me of a situation where I was in one time when I was in the clinical work. Suicide secondary to postpartum depression. Can the pregnancy be said to have contributed to the death?
Postpartum depression. Yes.
Yes, suicide. One has committed suicide. I think an incident, I think when I was working somewhere, I found a mother who she left the hospital and hanged herself in the tree. When we were looking for her, she was found hanging in a tree. She committed suicide. But now the question is, would you attribute, would you say that pregnancy had contributed to that death in a case of postpartum depression?
Yes, if I will repeat this, it is the best opinion of the certifying doctor if you are satisfied that the suicide was as a result of depression. Yes, but then I want to mention this. Whenever you have an external cause of death, the external cause of death will always be the underlying cause. So what you can do in this case is that you put as a contributing factor the pregnancy and depression in that line, part 2 of frame A, other factors that contributed to this condition. So you'll only have one line up under part 1 of frame A, only suicide, and contributing factor will be pregnancy induced depression. Does that make sense?
Okay.
Yes.
Yes, there's a question here. If a person dies of cancer diagnosed 4 years ago, and the cancer is likely cause of death, is the time of death then 4 years? The interval, I think this must be referring to interval.
Yes.
How do you say this? Maybe cancer, probably esophagus, or cancer, cervical cancer. How would you write this as a cause of death? How would you say it?
Okay, so you need to be specific on what cancer it is. That's the first one. And the second thing is about the time interval. The time you make the diagnosis is not necessarily when the cancer started. The cancer may have been there before. So in that case, I'll write more than 4 years. Cancer, more than 4 years, yeah.
Okay. All right, now another one also reminded me of situations where I was some years back. You brought a decomposing body. And this is case probably one year down the line, or decomposed body, or maybe it's like persons which have drowned and they're already decomposing. Yes. How do you attribute cause of death?
Yeah, so in this
case,
our
mom must have found some of this.
Yeah, so Dan, I added my line on you guys. Added your line on mine. I can't hear you well. Hilary, are you able to hear Dan well?
Yes,
my line.
I can hear you, Benson. I can hear you, Benson.
I had a bit of interruption. Sorry.
Okay.
Did you get me the question?
Yes, I did. So in this case, this is a similar example I gave about a dead on arrival. This is where autopsy by a properly trained pathologist has to happen. So if you find a decomposing body, you need a pathologist in this case to do a proper autopsy. I don't think you should, a doctor should go ahead and do the certification. I'm sure you'll end up only writing the cause of death is unknown.
Okay.
Yeah. So autopsy is important in that case.
I don't know whether we have some few lecturers here, maybe Dr. Long and Kiara Koski, or a few of them question on cause of death. I don't know whether any of them would answer. I know during our time this was not, but things have changed.
Right, I will say we do teach it. Unfortunately, I think we teach it a bit too early in year 3, year 4, during the main pathology course. And I now hope that my colleagues who teach clinical departments, obstetrics and gynae, pediatrics, and of course, internal medicine, that's where a lot of challenges are, may reinforce this training. So now that it's policy, and I'm glad WHO is providing a strong push towards this, then we will review our curricula to reinforce this training in more advanced years of undergraduate, and of course, specialty training as well. But I definitely would like to hear a comment from my other teachers, Dr. Kosgei and team.
Dr. Anne, Kiara?
Yeah, thank you very much. First and
Yes.
foremost, I want to really appreciate Benson and Dr. Walong for what they have presented to us. In OBS, we have the MPDSR sessions. So we actually do maternal and perinatal review. But my take home from today is really to cascade it, not just for postgraduates, but even into the undergraduate program. And more importantly, I think from this forum is really to take home the multidisciplinary approach. The gold standard is clear, it's autopsies, but that notwithstanding, with the revision with WHO and the ICD-11 coming in, I think it's really critical that practice makes perfect for all of us. We really need to go back to the drawing board and keep revising using genuine and hypothetical cases to improve on our death certification. I have one question though, and my question is this. When you do have a death that does occur, and more oftenly, I don't know why, but it tends to happen in the dead of the night, and we keep on backing it, that one, the death should be discussed, or the nurses are given the mantle of responsibility to actually break the news. I think we really need to look at the whole cascade. Certification comes at the end, but who is responsible for the debrief? What does your scope of practice allow you and not allow you to do? And lastly, as a clinician, are you being socially accountable? So it's a question at the same time, I'm giving us food for thought.
Right, food for thought, but I don't know whether you have, Benson, you have any insights on?
Yeah, I think this is, I mean, it's a very, very important point. The accountability, certification, as has rightly said, comes later. And when you do a death review, you really have to go the entire length, entire sequence of events that happened before. Our own accountability. Actually, if you look at these two cases that I put up, I actually thought there's something that the health workers didn't do that contributed to the death of this mother. Yes, she may have come with the obstructed labor, but what was our responsibility? How early did we intervene? What is our own responsibility? So that review really has to happen for the entire period the patient is in our care. Without that, we'll be doing certification for reporting. As I mentioned, our primary role to do the reason of doing certification is to improve the care of the patient. We can only improve the care of the patients when we review the entire process, including the systems issues as well. One mother died because there's no blood in the bank. And even if you're a very good doctor, you do everything that you're able to do, there's no blood, the patient is going to die. You need the systems review. So it is a whole comprehensive approach to this, in my view. Thank you.
And on that case, thanks. Somebody's asking what are your clues for the two cases so that they can mark themselves and see whether they've gotten.
Okay, so we can no, actually, I didn't put the answers, but we can go back to the questions, and these are questions we discussed, and we discussed each one of them for several hours with the hospital, and yes, it was quite challenging. But let me see if I can go back to them. I wish we could have people able to contribute to this as well. So let me just close this. Okay, so the first case was of a 36-year-old para 6 who was received at the regional referral hospital from a lower level facility with vaginal bleeding and retained placenta. She had, of course, delivered. She also complained of dizziness and palpitations. So in this case, dizziness, palpitation, these are symptoms that she presented with, so they can't make the death certificate. She reported that an attempt was made by the midwife at lower level facility to manually remove the placenta, but this was without success. On examination, she was found to be severely anemic. Her blood pressure was low, 85/50 millimeters of mercury, and pulse rate high, 110 beats per minute. Uterus was at 20 out of 40 weeks and atonic. and the vaginal examination revealed inactive bleeding, but no obvious perinatal or cervical tears. So a diagnosis of postpartum hemorrhage due to retained placental tissue was made. The admitting doctor also made a diagnosis of hypovolemic shock. So patient was given IV fluids and uterotonic and antibiotics, and a request for blood was placed. She was taken to theater for examination under anesthesia. During the examination, placenta was found to be morbidly adherent, and a subtotal abdominal hysterectomy was done, and the bleeding was controlled. Postoperatively, she couldn't get blood, her blood pressure dropped, and of course she died. She passed on. So here, the condition that kickstarted the chain of events was this morbidly adherent placenta. So that becomes the underlying cause of death. So you can then put the immediate cause of death will be the severe hemorrhage as the immediate cause of death. So in this case, I'll just write two things: severe hemorrhage, and of course, postpartum, the morbidly adherent placenta. Then in other conditions that contribute to the death will be, I will list all these things, but they're supposed to be the conditions in the mother. I will even include the information on the fact that this mother couldn't get blood, though it is not a condition in her, but it will help people to improve. It will help people to improve the care of the mother in the future, because as I said, the reason really we're doing this should not be just for reporting the data, but also to improve the care of the patient. So severe hemorrhage due to morbidly adherent placenta. But you can see actually from this case, much as this is the condition, you could see why this mother died is not because of these two conditions. I put it here purposely just to have this discussion. Why this mother died is not because of the morbidly adherent placenta. Yes, it kickstarted the event, but there's a bit of mismanagement somewhere. No blood, delays, and so on. So these are the discussions as one of the colleagues mentioned actually should happen. How do we improve the entire process of the care or entire system so that the mothers just don't die when actually we can avoid these deaths? Then the second condition is a 32-year-old.
Yeah, let's quickly go to the second condition. Yes, then
Yes.
we towards closing. Yep.
Yes, so the second condition is also the mother admitted with labor-like pains, a previous scar, blood pressure or admission was actually normal. BP was, the pulse rate was okay. They was at 38 weeks. Also was 3 to 4 centimeters dilated and so on. And then they made a diagnosis of Grabda 3-para-1 previous scar in latent labor and admitted for trial of labor. 12 hours later, contractions intensified, but fetal heart rate became irregular, or actually remained undilated. So she was scheduled for emergency section, but surgery wasn't done because the theater was busy. 6 hours later, the doctor decided, okay, let us do episiotomy and deliver the baby. Unfortunately, the lady sustained cervical tear and then bled profusely. So she was prepared for emergency section, and so of course she eventually died. Now in this case, what started the process of event, underlying cause of death, is actually the prolonged labor. Okay, her labor was prolonged. For the mother, it was prolonged labor. And then of course all these interventions that happened and so on and so on. But of course the immediate cause of death will be, again, the severe hemorrhage. I will not talk about hypovolemic shock in this case. For the baby, it will be, again, intrauterine hypoxia due to prolonged labor in the mother. So those are the two conditions that I'll just put in that. So the things here, you find this certificate will have very little information. But if you really do a death review of why this mother really died, you as I mentioned, your heart will skip a bit because there's a lot that could have happened to save this mother's life. She came way early. But then she eventually died when she was already in the hospital. So we always talk about delays of the mother delays, but this time there's no delay. Delay was actually on the mother's side, but delay was on the part of the health workers. So how can we address the issue of delays of the mothers in health facilities? So okay. These are the things that I will put. Thanks.
Thank you. Thanks a lot, and really appreciate your work. There's a brief from Dr. Media, Kenyatta National Hospital forensic pathologist. Dr. Media. Okay, I think there's just a quick comment here. Also, there's a follow-up. Is there a follow-up by the Ministry of Health on reported maternal or fetal mortality, since facility may choose not to do audit of the case in the fear that the facility didn't do as required to prevent the death, and if done, may be in the wrong side of the law. I think the terms of the policy guidelines, to the extent to know that it is not that this, the notes, the audit reporting and the notes are not for use for any legal cause. And should there be any cause to be taken, that takes another parallel line channel, because the audit is meant to improve quality of care, to prevent those deaths again. And it is no blame, no finger pointing. That's the principle that is in it. So it is meant, yes, thanks Dr. Kiara. Yes, as it is a no blame, no, it's just for learning to improve the quality of care. So should not be feeling, should not shy from it. Actually, the Ministry of Health, the Quality and Standards Department do follow that together with the department, the Division of Reproductive Health. Let me thank you so much, Benson. Thank you. Okay, we'll share we have been given the go ahead, the permission to share the slides. So we'll share the slides, and believe there will be from the Kenyatta National Hospital, the University of Nairobi. I think there's a team knows how to share the slides across the participants, to the participants. Now, lastly is to request the government chief pathologist or chief government pathologist, I don't know which comes first, but chief government pathologist, Dr. Johansson Duer, to give his final remarks. But otherwise, let me thank you, all the participants, our facilitators today, Benson, Hillary, Dr. Walong, and even Dr. Kinuthia, who's coordinating this from the Kenyatta National Hospital, and the secretariat, the team which is driving this. We look forward to more sessions on this, and the ICD-11, session will come on the 14th. I think Dr. Kinuthia will share with us, or somebody will share with us on the dates coming on October, on 14th of October. Dr. Johansson, the floor is yours.
Thank you very much, Daktari, for giving me and us the opportunity of being participants and of course, commenting on this session, which was very educative. I think death certification has been a very big challenge over time, and both for clinicians and also for forensic practitioners like me. Of course, many a time we come across causes of death assigned as cardiopulmonary arrest, and when you talk about cardiopulmonary arrest, is actually non-specific. And also, it does help in a purpose of planning and vital statistics and all that. I've also seen a situation in which even pathologists themselves assign some cause of death which don't make sense at all. Today, I've also learned, actually, because I've been talking about hypovolemic shock, and I've just realized that we are not even supposed to talk about hypovolemic shock as a primary cause of death or underlying. And I think what needs to be done is, as the presenter alluded to, we need to cascade all this and train more and more clinicians to be able to assign a correct cause of death, because some of these things go up to the national level, whereby we assign causes of death which are supposed to be to help in planning. So of course we've talked of this initiative also being taken to the university level. Dr. Along is here, and I think they should start a conversation at the university so that now in the curriculum, because some of these things are also attitude issues. If, say, for example, the attitude is correct for the time we're in the university and we come out here knowing how to assign cause of death, it will actually change a lot of things. Otherwise, I thank you very much.
Yes, very much appreciated. Thanks a lot, Dr. Johansson. Yes, going to the pre-service training at the basic, whether it's the clinicians, the clinical officers, or the other clinicians in the terms of the medical, the doctors, and then it's also later on, or not later on, but as well as the postgraduate level for those who may have missed that training earlier on. I think we are good to go. So sorry for the extending the time, but we really once again, thank you so much, colleagues, Dr. Benson, Dr. Hillary, Dr. Walong, and the entire team that prepared this. Looking forward for another session. I think as has been mentioned here, Wednesday, which is tomorrow, DKA management in children, same time from 2 to 3:30. And on Thursday, there's this week again, uptake and adherence to COVID-19 public health measures in the rural and the urban settings. Thank you so much, and bye-bye for now.
Thank you.
Thank you.
Thank you.